I want to thank everyone, and especially Migraine Canada, for inviting me in to speak today. It was interesting. I've been in practice about 32 years, and when I was first in practice, no longer in part of one of my training programs, the first conference I ever went to, where I got to choose which conference I went to, was on headaches. And so definitely appreciate what Migraine Canada does for the 5 million people dealing with headaches and specifically migraines. And I think it's great that we have an organization like this offering support. I'm a professor, clinical professor at UBC, so I'll go through some of my own disclaimers in just a moment. But I wanted to firstly acknowledge that I'm sort of a late settler on these lands, and that I am coming to you from Vancouver. So I work and have the privilege of living on the unceded territories of the Coast Salish peoples, which are comprised of 3 nations: the Musqueam, the Squamish, and Tsleil-Waututh nations. And as a late settler, I always need to recognize that I'm a visitor onto these lands, and I appreciate that our attendees are from other parts of the country and have other Indigenous, Inuit, and Métis lands that they may be working and living on. In terms of disclosures, because I'm affiliated with the university, I always have to share that where I've had some support in the past. Similar to the pillars of Migraine Canada, our work at the ADHD Center we've done research, and that's been supported by companies who have medications to do with ADHD. I've been asked to speak on behalf of companies that make medications for ADHD, and I've also done some consulting. Having said all of that, today's presentation isn't in any way sponsored by them, nor is it, or is any of the material or content being influenced by them. This is entirely my own content. And all the information that I'm sharing today is what we call evidence-based, which means that there's research to support everything I say. And there's actually something called clinical practice guidelines, which means someone took all the groups of people, took all the research out there and produced guidelines. And that's what I'll be referring to. If I ever give you an opinion that's my own, because I think this or I have found this in my practice, I'll let you know that it's my own opinion. Otherwise, you can understand or accept that everything else is research-based and not my own opinion, but what's been published in research. Kaylee said this already, and thanks to Kaylee and the Migraine Canada team, not just for inviting me in, but also doing a lot of the logistical stuff to get us all organized. And Kaylee already said this, but just to remind everyone that today's presentation is for educational purposes, and no treatments, whether it's a medication treatment or a non-medication treatment, should be started, changed, or discontinued without the guidance of your healthcare provider. And that's really important. Really, it's for education purposes today. So in terms of what I was asked to cover, was to talk about ADHD. I know many of you, if you've been affiliated with Migraine Canada, may know a lot about migraines already. So I thought the bulk of the time we would spend speaking about ADHD, what ADHD symptoms are, how it impacts people's function, what the genetics are, how common ADHD is, which is what prevalence means, and understanding ADHD and coexisting conditions. And that's a big area right now, is I think people are starting to understand ADHD, but ADHD coexists with other conditions, and one of the ones we're going to talk about is migraines. But aside from migraine, it coexists with many other conditions like anxiety, like depression, like substance use disorders and sleep disorders. We're going to talk about that a bit too. And I was asked to address some of the non-medicine and medicine treatments of ADHD. And then what we're all here for is, what's the intersection? Where does ADHD overlap with migraines? And what do people, if people have one, are they more likely to have the other? And if people are likely to, or have the other, are they more likely to have the first one? And so we're going to talk about some of the biological and lifestyle factors and some of the strategies for management, which I think will become kind of obvious. So a bit of a spoiler alert, I'll share some of my points right at the beginning. In terms of ADHD overview, I think people understand this, but ADHD is a neurodevelopmental condition, which means that people are born with it. It has a strong genetic basis, and we're going to talk about that in just a moment. But the symptoms typically are problems with attention, hyperactivity, impulsive behaviors, and challenges with focus, organization, and time management. And I think all of you, and I apologize, I've overly simplified this, but when you think about migraines, I think people think about significant and severe headaches. They think about this concept of an aura, that there's sensitivity to light and sound, that there's some nausea, fatigue, and sometimes cognitive impairment, and about 25% may happen with aura. I apologize for those of you that know migraine in a lot more depth than what I just rattled off there, but I just wanted to sort of lay out some of the sort of basics around that. And I totally appreciate that no two people have the same ADHD symptoms, and no two people probably have exactly the same migraine symptoms. So this is just a general statement, not specific. So let's dive right in. We've been talking a lot about ADHD recently. So 9 years ago, almost 10 years ago now, when we started the Adult ADHD Center, I'd had 30 minutes of training on ADHD in my entire medical school and residency. And I graduated medical school not knowing that little girls could have ADHD, because it was thought to be little boys, and specifically we were trained that they were often white boys. Don't know why we were taught that, but that was totally not accurate. And I didn't have this understanding that adults could have ADHD. Somehow we thought magically that people at the children that became teenagers, that become adults, something magical happened at the 18th birthday. Those 18 candles were somehow magical, and someone who was 17 or 18 years old with ADHD didn't have it when they were 19 years old. Well, that's not true, right? And so there's been a lot of stereotypes, misunderstandings, lack of education that have really influenced our myths and misconceptions of ADHD. But ADHD itself isn't new. We just come to a better understanding of it over the last 9 to 10 years. There's actually a nursery rhyme called Fidgety Phil. So Fidgety Phil, who couldn't sit still, there he is falling off the table there. So believe it or not, this was the stereotype that we were trained with, was that it was little boys who just couldn't sit still in the classroom, and that's who had ADHD. We didn't look at young girls and young women that well, and we certainly didn't think of adults. I'm not going to bore you with the slide, with all these details about how it's evolved, but just to tell you that the biggest change in ADHD diagnosis came in about 2013, when we started looking at ADHD and the different criteria for ADHD. I've got, as Kelly said, I've got a lot of information on these slides. Some of it I'm going to go through fairly quickly, but we're going to provide you the slide deck and the video, so you're welcome to slow it down and look at it with a bit more time when you have time. When we think about ADHD, I think people generally get the attention deficit part. So that's the problem with attention and problems with focus. I think people start to understand the hyperactivity part, which might be physical hyperactivity. So if I had ADHD, I might be fidgeting, I might be playing with my glasses, I might not be sitting still in my chair. And Kelly would say, "Oh, Dr. Parhar, Gurdeep, would you sit still? You're bothering all of us, but you're not sitting still and on the screen." That's some of the stuff that we think of when we think about physical hyperactivity. But what we sometimes don't think of is that people with ADHD also have impulsiveness. They do things impulsively. They might impulsively shop. They might be impulsively gamble. They might do binge drugs or binge eating or binge drinking. They may have sexual activities that they otherwise wouldn't be involved in because they have an impulse to be involved in a particular sexual activity. So this is what we're sort of understanding as the core symptoms, or the core symptoms of ADHD. What we're also understanding now is that even though we redefined and looked at the criteria again in 2013, there's still some other elements that the research hasn't caught up with. And those are elements around emotional dysregulation, and I'll come back to that, and dysphoria. And what this means is, even though the diagnostic criteria, and I'm going to present those to you in just a moment, even though the diagnostic criteria don't look at emotional dysregulation, which is people having temper tantrums or crying very spontaneously and without any really big sort of reason to cry or get angry, we know that a lot of people with ADHD have this, and we call that emotional dysregulation or lability or temper tantrums. We also find that people with ADHD can have low self-esteem and dysphoria. So the research really hasn't caught up to our broader understanding of ADHD, which we see in our practices. So what we do know is that people with ADHD don't always seem to listen when they're spoken to directly. They get distracted by external stimuli, but they also get distracted by internal stimuli. A classic question I'll ask someone when I'm diagnosing them for the first time, I'll say, "So what happens when you sit down to do some work?" And they'll say, "Oh, Dr. Parhar, I sit down and then a thought pops into my head." So that's an internal stimuli. It's not something around them that's distracting them. It's not the squirrel. It's not something they're looking out the window. It might not be their phone and Facebook. It's an internal distraction that can happen as well. People with ADHD often don't follow through on instructions and fail to finish their work. They have difficulty staying focused and make careless mistakes. They get impatient. That impulsiveness might mean road rage or doing impulsive things like speeding. They might fidget, as I talked about already. They might talk too much, a bit like I'm doing right now. They might be interrupting people. They are talking over people. When I'm interviewing someone with ADHD, a lot of times people with this symptom will actually interrupt me before I even finish asking the question. Now I interrupt people a lot, and I don't think it's because I have ADHD. It's because I'm just sometimes rude. My partner, the other Dr. Parhar, will say, "Why do you do that? Why do you keep interrupting people?" And I have to pull back and control myself. But when you ask someone with ADHD, "Why do you do it?" it's not out of rudeness. They just feel like if they don't jump in and interrupt or answer the question, that they're going to forget their thought, that the person may move on to something else. But that also means that they're breaking social etiquette. Social etiquette is let someone finish asking the question before you jump in and give an answer. But their life is like a Jeopardy game, right? It's like bzz, 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 and they're constantly interrupting. They forget daily activities or belongings like their keys, or forget to pay the bills, or forget to return a library book. They may forget to organize things in their room, and the place around them is disorganized. They have difficulty, as we said already, difficulty sitting in one spot. So when we think about some of the childhood symptoms, how might they manifest? Like, people don't come into me and say, "Oh, I forget daily activities." So what we think of then is what would have shown up in childhood compared to the way it shows up in adulthood. So if the child was making careless mistakes or not paying attention in class, in adult life they might have difficulty in lectures. If they're a university student, they may miss details in their work. When a child doesn't listen to, they're not listening to their teacher, they may not be listening to their parents, but with adult conversations, it may be their partner or their family members. Not keeping their desk organized or their bedroom organized might be someone who has lots of chaos around the house. Losing things as a child might be school supplies, but with adults, it's adult things. Similarly, in terms of the hyperactivity, a child who squirms around could be the adult that squirms around, or maybe this is the adult who says in a boardroom or a staff meeting, "I need to stand, my back is sore." Firstly, their back could really be sore, and maybe that's why they need to stand. But a lot of times people with ADHD stand because they're feeling restless. They're always on the go. They're always feeling like they've just got way too much energy. We already talked about talking too much and blurting out. They have a hard time waiting their turn. Many times I've heard my patients say to me, "Dr. Parhar, I go to the grocery store, I'll fill up the basket or the grocery cart with grocery, and then I'll go to the checkout line, and I'm not talking like 5, 6 people in front of me. There'll be maybe one, possibly two. I can't handle it. I'll put the basket down and leave the grocery cart and walk out of the grocery store." That's what people with ADHD do. They just get really, really impatient. Now, how common is ADHD? It seems like whether it's on TikTok or social media, everyone seems to be talking about it. Well, firstly, from the perspective of what I said before, where no one even understood that ADHD could happen in adults, I think, and I've been interviewed many times where people say, "Well, aren't people overdiagnosing ADHD? There's so many more people that are now being diagnosed and so many more people that are being treated." I don't see that as something wrong or something bad. If that diagnosis is accurate, it's made properly, and the person really has ADHD, they should be diagnosed. In fact, in the past decades, they were being missed. If more people are doing treatment for ADHD, and that doesn't necessarily mean medicine, we're going to talk about medications and non-medication treatments in just a moment. But if more people are getting treated, that's a good thing. Now, how common it is it? The research shows about 4.9%. I just rounded to 5% to do the math easier. And what that means is 1 in 20 people. So you can imagine if you're at a function, whether it's a work function or family function, there's 20 people there, one person in that room is going to have ADHD. So it's not rare. And if you're in a big company with 1,000 people, 50 people are going to have it. So it's very likely that we all know someone, work with someone, have someone in our family, extended family maybe, that has ADHD. So it's not super rare. Here's the part that is a bit more stressful. So in terms of the children, in how common it is in children, it's 5 to 9% of the population. So children with ADHD, 50 to 80% of them become teenagers with ADHD. And then of the teenagers that become ADHD, more than 50% become adults with ADHD. And so 3 to 5% of the population, like I said, have ADHD. A scarier number is that of the adults in Canada who have ADHD, 80% of them have never been diagnosed and never been treated. That's the problem, is that people are struggling in various parts of school life, home life, and it's because they haven't been properly assessed and they haven't been properly treated. I'm going to apologize for this slide a little bit, is that it's unfortunately probably going to entrench some stereotypes. I always be nervous with that. And the second is a study was done in the US, and they didn't look at transgendered, so they just looked at male and female, and I apologize for that. But the purpose that I keep the slide in is that when you think about gender differences, males tend to get diagnosed more in childhood than females do, for the reasons that we just said. They're fidgety Phil, they're disruptive to the class. The teacher, Miss Smith, says to the parents, go get Phil checked out. Phil's bothering me, he's bothering the classmates. Whereas Jane, whose ADHD could be just as severe, is more likely to have what we call the inattentive type or the daydreamy type of ADHD. Her ADHD and her focus problems could be even more severe than Phil's, but because she's not disrupting the class, she won't be as likely to get attention to her ADHD getting diagnosed. Now you have to be careful with that, because little boys can also be daydreamy and inattentive, and little girls can also be physically hyperactive. So you have to be careful that we don't fixate on those too much, because they can go either way. The other important part of this slide is to understand that children with ADHD tend to have either combined, so they have the inattention and also the hyperactivity is the biggest group, whereas in adults, the biggest group is inattentive. So you might remember some years ago, people started calling this ADD. I don't have ADHD, I have ADD. And part of the issue there was stigma. They didn't want to admit or share that they had hyperactivity, but they were okay saying that they had the attention part. And so ADD isn't really a thing, but when someone says ADD, I understand it to mean that they're saying that they have ADHD and mostly the inattention and focus issues, not the hyperactivity. So kind of touched on this already. I think the earliest time that anyone can be diagnosed with ADHD is probably in preschool or kindergarten, because that's when you see that child with their classmates, and the child is doing something a bit different, whereas the rest of the class is doing one activity and this child is doing something different. Children with ADHD can be really popular in the beginning because they're the class clown, they're making the farting sounds, the giggling sounds, doing jokes, doing funny things. But soon that class clown doesn't stay popular, and the classmates and the teacher and other people aren't comfortable with them anymore, and they sometimes even get bullied and they have self-esteem issues. In teenage years, that child with ADHD becomes a teenager with ADHD, and we all remember our teenage years, right? That's when we tested the boundaries and experimented, whether it was with substances or legal issues or driving or sexual activity. That's when teenagers are already testing the boundaries. Add into that a layer of decreased focus, decreased attention, lack of judgment for things, and that then is almost a bit of a perfect storm. The adult ADHD centers typically see people after that. And so when you think about adults with ADHD, typically they come to us when they're struggling in school or college, or they're in the workforce and they're struggling. They may have struggles with substances, they may have struggles with work. When we diagnose someone with ADHD, I usually start with showing a slide like this. And the purpose of this is that I want someone to understand that their ADHD is not bad parenting, it's not too much screen time, it's not someone who's lazy, that there is actually a biological difference in the brain of someone with ADHD and the brain of someone without ADHD. And on this PET scan, you can see how the brain with ADHD has less activity going on in it. And if you look very carefully, you can actually see parts of the brain there, this pink part, which actually has more activity than the non-ADHD brain. So in a way, there's maybe too much activity in some parts, or too little in some parts and too much in others. So there is a difference, and we're only just starting to understand what those differences are. Really what it comes down to, though, is the bottom part, the dopamine and norepinephrine. And what this means is that these are messengers that need to go between the brain cells, and what we think is happening in ADHD is there isn't enough of dopamine and enough norepinephrine going between the brain cells, and that's what leads to what we call ADHD. Now that's important for the whole brain, but is especially important in the frontal and the prefrontal cortex, where we do our executive functioning, laying down of memory, our emotional responses, our behavior, our judgment. The other Dr. Parhar, Nita, gives a whole 1 or 2 hour talk on this, on the importance of executive functioning and how executive functioning is compromised in ADHD. But just to leave you with the point and the plug that it's important that the prefrontal cortex is working well, and when it's not is what leads to what we know as ADHD. So the genetics, this may or may not surprise you, but after height, the most likely thing that you inherit from your parents is the likelihood of having ADHD. What does that mean? Tall people have tall kids, shorter people have shorter kids. I think that's kind of obvious. After that, it's the likelihood of having ADHD. When we started the ADHD centers 10 years ago, 10 years ago, we used to be very polite about this. We'd say, when we diagnose someone, do you think there might be someone in your family who might have something that looks like ADHD? Now, when I diagnose someone in my own practice, I'll say, okay, you have ADHD. Which of your parents has it? Which one of your kids has it? because it's that common. We can actually follow the pathway from grandparent to parent to grandchild. After that is the likelihood of having schizophrenia, and then the likelihood of having other health conditions. But look how tightly ADHD is linked to genetics. What does this mean in real life? It means that the likelihood of one person having ADHD when someone else in the family does increases many times. So when a first degree relative has ADHD, it increases 5 to 10 times that someone else will have ADHD. So the probability of a child having ADHD if their parent has ADHD is 57%. The probability of the parent having ADHD if their child does is 55%. And if one sibling has ADHD, it's 32% likely that another sibling will have ADHD. So just to tell you, there's a huge genetic connection. I touched on the gender bit, and just to expand on that a little bit, and you have to be careful because some of this is generalizing too much. But in general, what people have found is that the male types of ADHD tend to be the more hyperactive or impulsive. The female ones tend to be more inattentive. Males tend to externalize, females tend to internalize symptoms, and the other stuff I've sort of looked at. But how the coexisting conditions arise is that females tend to internalize and then get anxiety and depression, and males get more of the major depressive and the chronic disorders. Why is this important, and why am I sharing it with you? A lot of times females get missed and misdiagnosed. They'll see their doctor, their psychologist, and someone will focus on the anxiety and depression. Not that they don't have anxiety and depression, they may have that too, but miss the underlying problem which led to the anxiety and depression, which may be the ADHD. One tool, if you just want to note it down, that's good. It's good for screening for ADHD is a tool called the ASRS. It doesn't diagnose ADHD, and you can get this freely. It's called the ASRS. It's the Adult Self-Report Scale. And depending on how many yeses you have in these far right columns, will lead someone to think that they may have ADHD, and that just says then you should go for a full and more thorough assessment. So what are the criteria? How do we make the diagnosis of ADHD? The list of symptoms that I showed you on this earlier slide, I'll just go back to it and show it to you again. So when I was showing you this, these are the potential symptoms, right? And there's about 9 of them. So out of those 9, to diagnose ADHD, you need to have 6 of them in childhood, but only 5 of them in adulthood. So we actually start counting how many of those symptoms you have. The symptoms have to have been there for at least 6 months, which people by the time they see us as adults have it for many years. The symptoms have to start before the age of 12. So there's some people who think that, you know, I was totally fine, and then at 31, all of a sudden had ADHD. It doesn't work that way, unfortunately. And you can debate with me all you want on this, but right now the research is saying that it's a neurodevelopmental condition, which means that people have it, they're born with it, but the symptoms start showing up in kindergarten, elementary school, and you need to be there, and we need to have a history of that, which can make diagnosis kind of tricky if we don't have good records or the parents can't tell us what this adult was like before the age of 12. The symptoms have to be present in 2 settings, so home and work, home and school, social settings and school. But a couple of settings, the symptoms have to be really severe, that they're interfering with function. Everyone's allowed to be a bit forgetful. Everyone, like I said, like I do, I can interrupt people. That doesn't mean I have ADHD. Everyone's forgotten where they put their car keys or their cell phone or their wallet or their purse. That doesn't mean you have ADHD, but it's how severe those symptoms are and how often they happen. I had a patient who said that her bank will not give her another bank card because she's lost 6 already in that calendar year, and it was only November. She's lost 6. Or someone else who said their apartment manager won't give them another keyless entry fob thing because they'd lost 4, and it was only like February or March. So that means that's suggestive of something more significant going on, and that the symptoms can't be explained by something else. This is really important, the last one, because a lot of people may have symptoms that seem like ADHD, but there are other things that could medically explain this. This is why people that do questionnaires or they answer a few questions online somewhere, you can't have a diagnosis of ADHD that way. You really need to have an interview and assessment by a medical practitioner, psychologist, nurse practitioner, or a physician who's trained in this to make sure that they're not missing something else. Now, this sort of says, why is diagnosis so hard? And there's a lot of reasons for that. There's still a lot of physicians out there that don't believe in ADHD. People accommodate and adjust. Sometimes those childhood symptoms aren't present. People think, oh, it's just me. I was just never good at math. I was just never good at school. And they don't think it's a condition or a diagnosis, but that's just a quality that they had. My friends always tell me that I must have been bored during the pandemic if I made a mnemonic that actually had my name in it. All kidding aside, these are some of the areas that we can ask about when we're doing an ADHD interview. Are the symptoms interfering with performance? Are there attention issues? Is someone risk-taking? Are they hyperactive or impulsive? Did they have developmental or academic problems in elementary school and secondary school? Is it affecting relationships? I don't like to use the word type, but I like to use the word grouping. So there's sort of three groupings of ADHD. One grouping are people who have just the inattention, so the focus problems, people who have just the hyperactive or impulsive behaviors, and then people that have both. So those are the three groupings of symptoms. In adults, we see mostly the inattentive and second most the combined. Very few adults will have only the hyperactive. If an adult has hyperactive, they probably also have the inattentive, which then makes them combined. So when we do the diagnosis, it's very extensive. We look at various history, symptoms, talk to parents and teachers. If we can get that information, we observe them in the office. We have to make sure that we don't mistake it for other conditions that could coexist with ADHD. Now, there are many conditions, I'm not going to go through these just in the interest of time, but there are other conditions like depression, like bipolar, that can have symptoms that are like ADHD, but there needs to be ways that we can distinguish them. So I'll leave over that. And you can imagine that if someone has a learning disability and they have difficulty doing well in school or paying attention, that could look a lot like ADHD. Someone that has had past trauma can appear like ADHD. Someone that has severe depression or seizure problems or hearing or vision problems. So these are things that can coexist with ADHD, but otherwise can be misdiagnosed as ADHD, or ADHD is misdiagnosed, and it's really one of these things. Now, before we go into the migraine part of the presentation, I wanted to share with you one of the biggest parts of adults with ADHD. When you have children with ADHD, they often have what we call pure ADHD, meaning they have ADHD and they don't have anything else. With adults, what makes adult ADHD, in my opinion, so interesting, in other people's opinion, very challenging, is that when we see adults, they often have a coexisting condition. We often call it a co-pilot, is that the ADHD doesn't exist on its own, but the person also now has another condition with it. And that often confuses things. It confuses things in the diagnosis and might even confuse things in which one do we treat first. So I'm just going to plant the seed, and like I said, the slides will give you more than enough details on this, but anxiety is one of the big ones. So people with ADHD will also have anxiety, and people with anxiety will also have ADHD. And so we know that anxiety exists in the population, the general public have it, but we know that people with ADHD are more likely to get it, and more people with anxiety are likely to have ADHD. So what are the overlap? Well, people with ADHD and anxiety both are restless, they can't relax, they have difficulty concentrating and being irritable. The difference is that people with ADHD, they worry, but their worry is proportional to whatever's going on. People with anxiety disorders worry disproportionately. So there's some overlap and there's also some differences. The next condition, and you can look at the slides on that, the next condition that commonly appears with ADHD is depression. So a lot of people with ADHD also have depression. A lot of people that are diagnosed with depression are sometimes missed as not having ADHD when ADHD may have been there. So the same sort of logic as with anxiety, people with depression are more likely to have ADHD. More people with depression with ADHD are likely to have anxiety and depression. So what we think is going on with both of these, depression and anxiety, is that if things didn't go well for you, say you went through elementary school and you got really bad marks and you just struggled really hard and were putting in lots of effort but didn't get the results, how is that not going to make you anxious? How is that not going to make you sad? So ADHD that's not diagnosed can lead to a secondary anxiety and or a secondary depression. And what happens when you go to see a doctor like myself, or a psychologist or a counselor or a psychotherapist, we focus on the depression or the anxiety and we start treating or helping you manage that, not knowing that it's underlying ADHD that led to that depression and that anxiety. And the other way around, if you have severe anxiety and you're worrying all the time, of course it's going to affect your focus and concentration because you're distracted by the worrying. If you're depressed, one of the symptoms of major depressive disorder or being depressed is decreased concentration and decreased focus. So being depressed can affect your focus and attention. Being anxious can affect your focus and attention, but both depression and anxiety can lead to ADHD not being treated can lead to depression and anxiety. And so the overlapping symptoms between ADHD and depression, both of them lack of motivation, problems with concentration, sleep problems, and being agitated. And then there's the ones that are separate and different. Now, another condition that commonly coexists with ADHD is binge eating. Why I'm sharing these with you is that when you're seeing someone or you have ADHD on your own, it's very likely that you'll have one of these other things that further complicates the adult with ADHD. Binge eating is very common, more so in females than in males. And what we're thinking is that there may be some component of impulsive behavior inattention that feeds into the binge eating. The good news around binge eating, though, is that if someone has binge eating and ADHD, we can actually treat both of them with the same medications. And there's a really good medication research out there that we can actually support treating both things at the same time. The fourth condition that I wanted to share with in terms of coexisting before we go on to migraines is substance use. What we're finding is that a lot of people that have substance use disorder, that's the new term, if you're used to words like alcoholism or opiate disorders or addiction, those were the old terms that we used to use, but we're talking about something similar, which is substance use disorders. And with substance use disorders, what we know is that people who have ADHD are way more likely 2 to 41% of them are likely to have a substance use disorder compared to the people who don't have ADHD and might have a lower percentage. We have an opiate crisis in this country and in the US, and it frustrates me that people are still dying of opiate problems and opiate use disorders when we could find the solution for the COVID pandemic within a couple of years. We still haven't solved the opiate problem. My belief, this is my belief now, is I think we won't solve the opiate problem or the substance use problem that's killing people if we don't also address ADHD. So another way to say it is a lot of people that have substance use disorder actually also have undiagnosed ADHD. And what we think is going on there is that people with ADHD can have all sorts of substances that they use. But what we think is going on is there's something called dopamine. And the dopamine that is released when someone's using a substance. Remember I said at the beginning that people with ADHD and don't have dopamine levels that are high enough? Well, maybe the people having substance use disorder problems are using substances because their dopamine is too low. So here's the good news though. If you treat ADHD, you can actually improve substance use disorders. Quick comment about cannabis. Just because we have to talk about it, there's very little research to show that cannabis actually helps with ADHD. Now, before anybody gets really upset on this talk about this, that doesn't mean cannabis doesn't help people with symptoms that come out of ADHD. So if ADHD is causing someone to be anxious, if ADHD is causing someone to have a sleep problem, sometimes the cannabis can help with that. Does it actually treat the ADHD itself? Perhaps we'll find research saying in the future that it does. Right now, the research isn't really big on that. Now, the other thing I wanted to go on to here was talk about sleep. So when we think about sleep, when people say, well, you know, my physician or my nurse practitioner prescribed me an ADHD medicine, which is a stimulant for ADHD, is it going to interfere with sleep? So here's the thing with sleep. People with ADHD generally have difficulty sleeping. And so when we treat their ADHD with a medication often or with non-medication approaches, their brain finally turns off so they can sleep at night. Or the ADHD gets better so they get more done during the daytime, so they're physically, emotionally, cognitively exhausted at night, so they actually fall asleep. So in our experience, people with ADHD sleep better when their ADHD is treated. And so ADHD tends to get better. If there is someone whose sleep disturbance gets worse with the ADHD medicine, there are ways that we can work around that. Now, I'm going to leave this and go into the management and then into the migraine section. People often want to talk about medications, but my belief, and a lot of people believe, that really we need to look at the non-medication approaches before we dive into the medications. And that means educating people about what ADHD is, looking at the behavioral aspects of ADHD, and that may mean things like coaching. So if someone has anger fits or crying fits, they may need anger management, they may need coaching. If they're in the wrong job or the wrong career, they may need vocational. There may be lifestyle stuff. What our parents told us to do, go to sleep at a regular time, exercise, eat regular meals. Believe it or not, it works. People with ADHD do best when there's a schedule and a routine and they stick to it. I'm not a psychotherapist or counselor, but I can tell you that my colleagues that are and friends that are do a lot of good work with CBT, IBT, and all these other modalities, and they do work for ADHD. And like I said, people with ADHD do best when there's structure and predictability in their daily routine. That's not just their work routine and their school routine, but their home life, their social activity, their wellness stuff. I think this was sort of already covered. Now, medication. Everyone always wants to talk about medicine when it comes to ADHD. It really works. And I'm not here to push medicine, but I can tell you that medications for ADHD are very, very effective. In fact, the medications for ADHD work better for ADHD than antidepressants work for depression, and anti-anxiety medications work for anxiety. So the medications work, but not only do they work for ADHD, when we treat someone's ADHD, what these graphs are meant to show is that people's depression gets better, their anxiety gets better, their other conditions actually improve as well. Here's a little thing to think about when you think about medications for ADHD. Think about someone who's being thrown into a deep pool and they don't know how to swim, swimming pool, and they don't know how to swim. What the medications would do is give them a flotation device. It's like giving them one of those noodles or something that they can float with, and so they stay above the water. That's what the medications do. They stop you from drowning. Now, if you want to get to the other end of the pool, what are you going to need? You're going to need a goal. You're going to need to know which end of the pool you need to go to. So that's a goal. But you also need some skills. You're going to need to know how to kick your feet and how to swing your hands or arms. So you need skills. So the medications will keep you floating, but the medications won't help you achieve your goals. So in order to achieve your goals, you need to have the goal, be able to set the goal, and you need to have some skills. And that's what the coaching, counseling, and other professionals and interventions do. The medications, whenever we have medications, we are always looking at the potential side effects. A lot of coexisting conditions and other activities get better. There could be some side effects. People with ADHD, on ADHD medications, often say they don't feel as hungry. I talked about the sleep effects. They're psychostimulant medicine, so they can speed up heart rate and increase blood pressure. So we're often looking for making sure they don't have cardiovascular effects. I already talked about this, is that the ADHD is caused by low levels of dopamine and norepinephrine. So what the medications do is they increase the dopamine and norepinephrine levels. I think we can go over that. There's two groups of ADHD medications. There's the methylphenidate group, more popularly known as Ritalin, and then there's the amphetamine family. I put this graph in just to show you that both groups work about the same. Then after that are other medications in the blue that are non-stimulants, and in the black are ones that are not even ADHD medicines, but sometimes people go on them. But these top four are the ones that are approved by the FDA. I'm going to go to the actual choices of medications. So in the green are what we consider first line. So in the two groups, so here are the two groups of ADHD medications. There's the amphetamine family, and then there's the Ritalin family. The green are what we consider first line or first choice. So Adderall XR, not short-acting Adderall, Vyvanse, bifenthrin, Concerta, and Foquest. Any five of those are equally good to be used as a first line or first choice for ADHD. In the blue are the ones that we would use if for some reason we couldn't use the green ones. So we try to stay away from the short acting as much as possible and use the long acting, once a day psychostimulant medicine. The non-stimulant medications, and there's two of them in Canada, for adults it's just the atomoxetine. And then for children, it's atomoxetine and Intuniv. And we use those when someone can't tolerate one of these stimulant medications. I already mentioned that both groups of medications work really well. And if one medicine in one family doesn't work, then we switch over to something in the other family. Now, migraines. We know that there's a lot of overlap. This fishbone thing was meant to show that, but I've got other slides that are going to show that in a little bit more detail. So there's been research done that show that there's a 2 to 3 times higher risk of migraines in individuals that have ADHD, especially those people with migraines who also have aura. Conversely, migraine sufferers often exhibit ADHD-like symptoms, such as inattention during attacks. And that seems kind of obvious, right? You have a severe migraine, in addition to all the head pain and the aura and the visual changes. How is that not going to affect your attention? Migraine and ADHD coexist stronger in women and increases with age. And we're sort of understanding that hormones likely do play a role. And so certainly they play a role in how ADHD presents for women in the younger ages and also near menopause, and also likely play a role in migraines or vascular headaches as well. So what is the overlap? What we understand is that there's probably an overlap in two areas: the dopamine effects and the genetic causes. So the dopamine. So I already said that people with ADHD have lower levels of dopamine, or not levels that aren't high enough. So if we think about it that way, ADHD is characterized by reduced dopamine activity. And so that's reducing attention and impulse control. Migraines, we think, are linked to dopamine fluctuations with heightened sensory sensitivity and pain perception, and then the gene variants that affect dopamine as well. That's probably the connection there. In terms of the genetic overlap, there are genetic predispositions, and there are shared gene overlaps between both the dopamine and the neural activity. And there's some mutations in the genes that affect dopamine reuptake, which we think then could be affecting ADHD and migraines. Now, there's another area that's really important when we're thinking about overlap between migraines and ADHD, and that's around psychiatric coexisting conditions. So you heard me go through that ADHD coexists with depression and with anxiety and sleep disorders and substance use disorders and binge eating disorders. Well, that happens with migraines as well. Both conditions frequently co-occur with mood and anxiety disorders, which may stem from them having the same neurotransmitter, maybe dopamine imbalances. So that dopamine dysregulation could be leading to the emotional issues, which then lead to the coexisting conditions. So common contributing factors. I don't like the word trigger, but that's what was used in this research. Both conditions, migraines and worsening of ADHD, can be triggered by stress. Both can be affected by lifestyle. Poor sleep, diet, hydration can make both worse. Both, as I already said, have genetic overlap, and we already talked about how hormone changes, especially in women, can affect ADHD and migraines. So what does this mean? Well, if someone's ADHD is exacerbated by them having a migraine, well, then the migraine could be actually making their ADHD worse because they missed some school or they missed out on some activity or work tasks that they were supposed to do. Missing work and school then might affect some management issues. Chronic pain increases stress and isolation. So it's understanding how these actually may interact with one another. Now, headaches as a side effect of ADHD stimulants was one of the things I was asked to talk about. So another way to think about it is this: if someone doesn't have headaches and they're diagnosed with ADHD and they're put on ADHD medications and then they get migraines or headaches, often in my experience, it's due to dehydration. That somehow they're forgetting to drink water or they're not drinking enough water, and drinking even 1 or 2 glasses often helps the headaches. Now, if that doesn't work and the headaches are definitely worse with the ADHD medicine, then we may not have a choice other than to reduce the dosage or switch the person to another ADHD medicine. But most of the time, drinking more fluid actually helps with that. But the second bullet is what actually my experience is more, is that ADHD medicine actually helps people with their migraine symptoms. Not sure, totally understand how. Maybe it is the effect, but in my experience, people that I start on ADHD medicine who also already have migraines will tell me that their migraines are actually better once the ADHD medicine started. They don't get the migraine headaches as often, they're not as severe, they don't last as long, and so forth. One of the things that we do need to monitor for is that ADHD medicines do cause a decrease in appetite. Now, if you're somebody who's like me, missing the occasional meal would probably be good for my weight. But for people who are underweight or have eating disorders, missing meals is a big problem. And so when appetites go down or people are forgetting to eat, that can in itself, with the hypoglycemia that happens, then bring about migraines. If the ADHD medicine is interfering with sleep, or changing the sleep pattern, that can also bring about migraines. So this is very much an individual type of thing that we'd have to monitor each person for separately. And then in terms of comprehensive management for ADHD and migraines, I think monitoring the symptoms really closely to see if we can find a pattern. Was it the ADHD medicine, or on the day they didn't take the ADHD medicine, did the migraine still happen? Tailoring the medication plans, so adjusting it, fine-tuning it, looking at consultations. Do they need to see a neurologist? Do they need to see the ADHD doctor? Looking at some of those mindfulness practices, the meditation, the breathing exercises, the yoga, they do actually help both to some degree. The emerging topics, so it's one of those stay tuned kind of comments, is we don't know enough about these areas, but I thought I would sort of tease you with where the research is going right now. We are looking into the gender identity challenges in terms of not just male-female, but people that are not binary and transgendered, and trying to look at how that affects both migraines and ADHD. There's this whole understanding and link between gut and brain, and some of you may have heard about biomes or gut biomes, but what we're starting to understand is that the gut health does affect brain function, and when it affects the brain function, it could affect both migraines and ADHD. And understanding sensory processing challenges. The other Dr. Parhar gives a talk on sensory processing and ADHD, and there's a lot of connections between people who don't process inputs, whether it's a visual input or a sound input, and how that affects ADHD and how ADHD is affected by those inputs. We know that people with migraines also get affected by those sensory inputs, whether it's strobe lights or noise or sounds or smells. And that can bring about a migraine, or while they're having the migraine, they could be experiencing these changes in sensation. So clearly these are areas that we're going to need to look at. So in summary, and I'm happy to go back to any of those, I know I went through it fairly fast. In summary, ADHD migraines likely arise from intertwined dopamine and genetic vulnerabilities compounded by environmental stressors. Addressing both conditions in a holistic way, targeting the dopamine pathways, is probably the way to improve outcomes for both. Kaylee, I promised you I'd be done by 8:20, and I think I'm at 8:19. So despite my switching over to my auctioneer voice, I did get through it. Yeah.
That was fantastic. Thank you, Dr. Parhar. We did receive a bunch of questions, so I'm glad we have time remaining to answer them. And just a reminder, if you do have questions, please put them in the Q&A. I did notice a few in the chat, so I'll try to get to those as well. But before we get to the questions, just to note that we hope that you did find this webinar valuable and informative. I know I certainly did. There was so much information. And if you'd like to support Migraine Canada and help us continue offering resources like this, we invite you to make a donation. I will be sharing the donation link, or you can visit our website at www.migrainecanada.org. As a not-for-profit charity, we rely on generous contributions to fund essential programs, including these webinars. Every donation makes a difference, and thank you all for your support. Okay, so with that, I'm going to get to the questions.
Just make a footnote on that. This is really important, what Kaylee said, is that we're very fortunate to have an organization like Migraine Canada that does help with the research and the education and the advocacy, because I think migraines are one of those things that people don't appreciate, and in terms of how disabling migraines can be. As someone who's a disability physician and occupational physician, aside from my ADHD life, I can tell you that migraines for people who have them are a big part of their being, and how much it impacts their home life, their work life, their school life. And so any support we can give to Migraine Canada, I think, would be appreciated. And congratulations on the amazing work, Kaylee, that you and your team are doing.
Oh, thank you so much, Dr. Parhar. I appreciate that. We believe our work is so important too, and it's what keeps us going. Okay, so to the questions. We have, and this may have been included on one of your slides, is guanfacine safe and or recommended for people with chronic migraine and ADHD who do not tolerate stimulants?
And the joy of having so many slides is I can go back to one of them.
Awesome.
So you'll remember that I said that these two at the top one is the Ritalin family. This is the amphetamine family. They're the medicines we start with because they're super effective. 80% of people will respond to them. The next two, atomoxetine, the other name for that is Strattera. The other name for guanfacine is Intuniv. So on this table, the first line are these two are the amphetamine family, Adderall XR, Vyvanse, and these are the other ones. Now on the second page are the two that you're asking about. So I only use, well, first of all, guanfacine or Intuniv can't be used in adults. You'll know adults that are on them, but I'm really, really conservative, and Health Canada's only approved it, if you look at the fine print over here, only to the age of 17. So I tend not to put people on guanfacine in adults, but children, sure. But to answer your question, there are people who cannot take psychostimulant medicine either because it brings out migraines or worsens some of their symptoms, or they get really anxious. And for those ones, and when we've tried a few of these and none of them work or they can't tolerate them, that's who I then put on atomoxetine or Intuniv. So to answer your question, I think it's a good second choice, but my experience now, these two don't have that boom, I call it the boom effect. They don't have that boom effect, that dramatic improvement in ADHD symptoms as these ones do. And for people that are looking for that dramatic improvement in their functioning, it's not that these medicines don't work, but you have to adjust your expectations. It's a gentle improvement.
Okay, thank you. Next question. And I know that you have clinics across the country. So this person's asking about, from Ontario, is assessment and diagnosis costs covered by provincial healthcare plans? In their case, OHIP.
Excellent question. So if you think you may have ADHD, I think your first stop is your primary care practitioner. So go back to your NP or your family physician, or if you're seeing us in Ontario, you call them psychotherapist or registered clinical counselor or psychologist, go to them first. and say to them, you've been thinking about ADHD, and then you heard this talk on it, and I think you might have it, or you might know someone who has it, and they'll direct you to how to do it. So under OHIP, if you can be assessed by a physician, so a psychiatrist or a family physician, or there's a nurse practitioner that's working in the public model, they may be able to help you with a diagnosis. Why centers like the one that I helped start are needed or thought to be needed is that the wait times in those other ones were just so long. But by all means, please try to go through the public system first and see if you can get in to see a psychiatrist or family doctor. Other big arm for us is we've been doing a lot of training of healthcare practitioners across the country. And my joke always is that by the time I retire, I hope I put myself out of that job, which is that enough people are comfortable diagnosing ADHD. Please don't get upset with your primary care practitioner. If they're anything like me, they didn't have the full training in medical school or residency. And so they may not feel confident diagnosing ADHD, but they should refer you to someone who's covered under OHIP or your provincial plan that can.
Thank you. Next question. Are there any or many documented connections or overlap of undiagnosed ADHD, migraine, as well as fibromyalgia and chronic fatigue?
Excellent question. So yes, and yes. So firstly, when you think about mood disorders, when you talk about psychological disorders like depression, like anxiety, those conditions do overlap with chronic pain conditions. So a lot of people, I treat a lot of chronic pain in my practice aside from ADHD, and I can tell you that people with people with depression and anxiety are more likely to have fibromyalgia, chronic pain syndrome, and so forth. And so that's quite common. And likewise with migraines and stuff as well. And the other part to your question was ADHD overlapping with all those? Yes. And we just don't necessarily understand all the overlaps. Like we were saying before, there may be genetic, there may be hormonal, but chronic pain and chronic pain conditions put people more likely to have migraines. And people with chronic pain conditions are also more likely to have ADHD. So unfortunately, there's an overlap of a lot of these really tough conditions.
Thank you. And there were a few questions about the overlap with FND as well, functional neurologic disorders.
Yeah, so that's a little bit trickier. And I think that the research is not as robust as we'd need it to be. Hopefully people will continue studying this. My thinking is that when you think about the way the brain works and what leads to functional neurological disorders, there's got to be some connectivity between neurons and brain cells and other parts of your nervous system. And it's hard to think there wouldn't be a connection. But let's stay tuned again for some of the research to give us more information on that.
Okay. Can an individual be on a serotonin reuptake inhibitor for depression and an ADHD dopamine stimulant?
Excellent question. I was hoping somebody would ask that. So back to my slides earlier where I was talking about depression and depression and ADHD and anxiety. That's the nice thing about these. So when we're thinking about ADHD management with these other coexisting conditions, you can actually treat both at the same time. So an SSRI with an ADHD medicine, I'm just going to show you this slide here with the depression. So if someone is on an SSRI, selective serotonin reuptake inhibitor, like I'm going to name some names, sertraline, Cipralex, escitalopram, Luvox, any one of those, or even not just an SSRI. I know the question was about SSRIs, but SNRIs, which are like venlafaxine, duloxetine. So someone is on those for depression or anxiety or chronic pain, and then they also have ADHD, yes, you can actually be on both medications at the same time. There is a slightly increased risk of something we call serotonin syndrome, but it's not a really, really high risk. So the doctor does need to, or your NP does need to tell you there's a little bit of risk of this thing called serotonin syndrome, and certainly your pharmacist will tell you. But I can tell you I have a lot of patients where I'm treating their depression with one medicine and their ADHD with another, and it's working very well together. And in fact, sometimes I need to treat both at the same time.
Okay, thank you. I think we have time for one more question. This one's a bit specific. Okay. Can hypersensitive body pain with no anti-inflammatory markers with blood tests be a side effect of Vyvanse? And if so, what would be an alternative for treating ADHD?
It's a very specific question, but it's a very good one.
Mm-hmm.
So, Vyvanse is a psychostimulant medication. I'll just say, I'll bring it back so people know which one I'm talking about here. So, Vyvanse is in the second red there. It's in the amphetamine family, and I'll just show you the medicine. It's here, and it's one of the ones like I prescribe all 5 of these, and it's one of the 5 that are first choice. Now, you have to remember, a stimulant increases the connections between nerve cells. So a lot of people with stimulant, think about it, if you're going to compare it to something, think about it as if you had too much coffee or an energy drink. For some people, it does make them a bit more stimulated, maybe irritable, maybe a little bit hyper. I use the word wired. It makes you feel a bit more wired. So you can imagine that if you have a hypersensitivity to something already, and now somebody gives you some stimulation, it could make that worse. I'm using that word could very intentionally because there's a lot of people where that doesn't happen. And in fact, their hypersensitivity actually gets better on the Vyvanse or on the ADHD medicine. So that's the struggle and also the charm of treating ADHD is I've yet to meet 2 people after 25,000 people that have their ADHD exactly the same with the same reaction to medicines or the same side effects of the same coexisting condition. So, so leave it to say that if someone is hypersensitive to things, there is the possibility that a psychostimulant could make that sensitivity worse. But let's be optimistic and hope it makes it better.